Welcome back. We are on Chapter 26, Abdominal Emergencies. We will be discussing the following topics: abdominal anatomy and physiology, abdominal pain or discomfort, abdominal conditions, and assessment and care of abdominal pain or discomfort. In this first section, we will discuss abdominal anatomy and physiology. Your abdomen contains many organs from several different body systems. It can cause confusion when determining the cause of abdominal emergencies because there are just so many different things that can happen in that abdominal cavity that can cause pain and swelling and so forth. So you want to do a thorough patient assessment, which is very key to understanding what's going on. So if you have a female who's complaining of abdominal pain, you want to first ask, is there any chance you could be pregnant? Do you have your gallbladder? Do you have your appendix? Have you ever had cysts on your ovaries? And just keep going down the line of anything that could have potentially happened. Was there trauma to the abdomen, and there could be a spleen laceration or a liver laceration of any sort? So there's lots of different things that can happen in the abdomen, including small bowel obstructions and so forth. So specific diagnoses might not be necessary, but treatment is the same for most conditions. So you might not need to know exactly what it is, but essentially, how are you going to treat that? And as EMTs, you can't really do anything for pain medication. And I know that they don't always like to give pain medication for abdominal emergencies just because you don't want to mask the pain when they do get to the ER and are able to be assessed. So the abdomen is that region between the diaphragm and the pelvis. It contains many different types of organs that provide the digestive, the reproductive, the endocrine, and the regulatory. So remember that the abdomen contains a variety of organs that accomplish a range of functions for the body. So your digestion, your secretion of insulin, your filtration of blood, and the removal of toxins from the body are functions performed by those abdominal organs. So it's a very important organ or system within your body. So here is the organs of the abdomen. Remember in the last couple slides ago, we talked about the female anatomy versus the male. So the female anatomy is potentially pregnant. We talked about asking if they've had their gallbladder taken out or their appendix and so forth. They might have cysts on their ovaries, whereas men won't. So just again, there's lots of different things that you have to know, and knowing that anatomy of both the female and the male is pretty important. So the abdomen is divided into quadrants. So you got your right upper quadrant, your left upper quadrant, your right lower quadrant, and your left lower quadrant. So that's the RUQ, right upper quadrant, and so forth. It's used to describe and identify areas of pain, tenderness, discomfort, injury, and other abnormalities. So anatomically, the abdomen is divided into 4 quadrants, and what you want to use is that midline and the umbilicus as your dividing points. So if you take from your nose straight down, that's going to be that midline, and then the point across is find that umbilicus and draw a line straight across your abdomen, and that would be where you'd have your dividing point of the right upper and right lower quadrants versus as well as the left upper and left lower. So as you can see here, this is how they divide the 4 quadrants using that midline and that umbilicus to divide that abdominal cavity. Organs of the abdomen start out with the peritoneum. It's the thin membrane lining of the abdominal cavity and covering each organ. Then you have the parietal peritoneum, which is attached to the abdominal wall. And then you have your visceral peritoneum, which covers each organ. So most are enclosed with a parietal peritoneum, which a few lie in the extraperitoneal space, which is outside of that peritoneum, which is the kidneys, the pancreas, part of the aorta, which lies in that retroperitoneal space behind the perineum. And then your bladder and part of the rectum lie inferior to that peritoneum. So the most organs are contained within the peritoneum, but some are also located in that retroperitoneal space. Then the reproductive organs are contained within that abdomen and are very different from women than what they are of men. So again, going back to knowing and understanding what each of those mean. Female reproductive organs and structures lie within the abdomen and the pelvis, which are your ovaries, your fallopian tubes, and the uterus. You have your largest blood vessels, which are the aorta, the inferior vena cava, the hepatic artery, the splenic artery, and the iliac artery and vein. So here's your peritoneal and extraperitoneal space. So knowing and understanding these is, again, it's very important to know which are in which space, because on your test there will be things in there that will ask about if it's in the peritoneal or the extraperitoneal space. In this section, we're going to talk about abdominal pain or discomfort. So for that abdominal pain or discomfort, we will first start with the visceral pain. So it originates from the organs within that abdomen. There's fewer nerve endings, which allow for only diffuse sensations of pain. Frequently, it's described as dull or achy, intermittent, crampy, or colicky pain may result from hollow organs. And persistent or constant pain often originates from those solid organs. So remember that both peritoneal and retroperitoneal organs can cause pain in the abdomen. The visceral pain originates in the organs within the abdomen and is often described as dull, achy, or potentially intermittent. Next is parietal pain. It originates from the parietal peritoneum. It has many nerve endings and allows for pain that is easier to locate and describe. It's frequently described as sharp pain and is often constant and localized to a specific area. So remember that parietal pain arises from the parietal peritoneum and is often described as sharp, constant, and localized to a particular area. So parietal pain is localized to a particular area, sharp and constant is how they will describe that. Next is tearing pain. It's not the most common type of abdominal pain. It originates in the aorta or the stomach. It is actually the cause of separation of layers of the aorta caused by an aneurysm. So when you hear tearing pain, you can assume that there's probably an aneurysm happening. The retroperitoneal location of the aorta causes the pain to be referred to their back. And then ulcers in the stomach can also cause a tearing pain. So remember that tearing pain typically refers to a dissection of the abdominal aorta. Next is referred pain. So it's the perception of pain in skin or muscles at a distant location. So the abdomen has many nerves from different parts of the nervous system. The nerve pathways overlap as they return to the spinal cord. And then pain sensation is transmitted from one system to another. So remember that referred pain is felt in places other than the place where the pain actually originates. So you might have somebody complain of abdominal pain, but they're actually having shoulder blade pain or back pain or neck pain. So that's a referred pain. You might feel the pain in the abdomen, but you also feel it in the back. Or you might not even have any pain in the abdomen, but its referred pain is into the back. In this section, we're going to talk about abdominal conditions. First one we'll talk about is appendicitis. It is an infection of the appendix. Signs and symptoms are nausea and sometimes vomiting. Pain that often is initially referred to the umbilical region, followed by persistent right lower quadrant pain. If you have a rupture of the appendix, it's a sudden severe increase in pain and the contents release into the abdomen, causing severe peritonitis. Next is peritonitis. It's the irritation of the peritoneum, which is usually caused by foreign material in that peritoneal space. So the parietal peritoneum is very sensitive, especially to acidic substances. Irritation then can cause involuntary contractions of the abdominal muscles, and signs and symptoms to look for is abdominal pain and rigidity. Next, we're going to talk about cholecystitis or gallstones. So it is the inflammation of the gallbladder. It's often caused by blockage of bile flow by those gallstones. Symptoms typically worsen by ingestion of fatty foods. Signs and symptoms are severe right upper quadrant or epigastric pain. And you will sometimes have pain often referred back on the shoulders. Next is the pancreatitis. So the pancreatitis is an inflammation of the pancreas, which is common in patients with chronic alcohol problems. The pain from the pancreas is found in the epigastric area. And because of the retroperitoneal location of the pancreas, behind the stomach, the pain may radiate to the back and or shoulders. This is considered a serious condition, which in advanced cases can actually present with the signs of shock. So you have to be careful with that as well. Next, we'll talk about gastrointestinal bleeding. So it's bleeding from within the GI system, which can occur anywhere from the esophagus to the rectum. Depending on the size of the source blood vessel, GI bleeding may be gradual or it can become sudden and very massive. So because of this type of bleeding that occurs inside the lumen of the esophagus, the stomach, or intestines, blood eventually has to pass out through the rectum and or through the mouth, so either by bowel movement or by vomit. So patients may report that the passage of abnormal stools are considered dark, black, or even maroon in color, and they can appear tarry in the way that they explain it. Or they may pass just frank blood without stool from the rectum, so it might just be straight up blood. So patients who are bleeding from the upper GI source, which is going to be the esophagus, the stomach, or the first part of the small bowel, this may also exhibit vomiting in frank blood, or what they would consider that looks like coffee ground vomit. The coffee ground appearance is due to the partial breakdown of the blood by that digestive system, or the enzymes, I should say. Sorry. So GI bleeding can be associated with pain, but often occurs without pain. So painful GI bleeding is most commonly occurs in patients with perforated ulcers in the stomach, or those gastric ulcers. So these lesions are the result of an acidic gastric juices wearing a hole in that upper gastrointestinal system. So if the erosion eats into the blood vessel, the GI bleeding will result. So if the acid causes erosion all the way through the stomach or the proximal small bowel wall, then this is the very acidic liquid that leaks into that peritoneum, resulting in significant abdominal pain from the chemical irritation and the peritonitis. So patients with GI bleeding may present in many different ways. So if the source vessel of the bleed is a small one, the patient may experience a slow loss of blood, referred to as a chronic gastrointestinal hemorrhage. This results in the patient becoming pale and weak over periods of days to weeks and unaware of the bleeding actually inside their body. So the body can actually compensate for the most of this blood loss over a period of time, but eventually that patient develops signs and symptoms of shock. So if the source of the bleeding is a larger blood vessel, the patient may present with a brisk bleeding from either the rectum or vomiting of either the red blood cells or the materials that resemble what they would call coffee ground substance. So this type of bleeding is actually associated with the sudden onset of signs and symptoms of hypoperfusion, and the majority of patients with GI bleeding do not actually have associated abdominal pain. So furthermore, like the patients with esophageal bleeding, or it's often from a condition called esophageal varices, which you'll probably hear that more often, it presents a very particular challenge, actually. So the blood vessels of the esophagus can become vulnerable, and often due to chronic alcohol ingestion or hypertension in the liver. So if the blood vessels rupture, massive upper GI bleed can actually occur. And from the blood from that bleeding esophageal varices enters the stomach, which then that blood is an irritant to the stomach and causes vomiting and copious amounts of blood. This also can cause shock and cause airway compromise. So signs and symptoms that you're going to probably see or hear about is dark colored stool, maroon to black, and often tarry. They have frank blood from the rectum, vomiting or what they consider coffee ground appearing blood, vomiting of frank blood, like straight up blood, and then the pain can be absent or it can be very, very severe. So you have a very large range of different things that it could be. The next one we're going to talk about is abdominal aortic aneurysm, also known as a AAA, which is ballooning or weakening in the wall of the aorta as it passes through the abdomen. So when the aorta is weakened, it can actually rupture quite suddenly or leak relatively slow. It can also dissect, which means that an inner layer of the aorta actually tears. So the high pressures in the aorta spread apart the layers of the vessel, tearing the internal layer of the blood vessels and allowing blood to escape into the weaker outer layers. So as the pressure continues to exert force on the aorta, the area of the dissection can actually spread. So in some cases, the dissection spreads so far that it interferes with or even eliminates the blood flow to the artery that branches off the aorta. So in this case, you may see decreased perfusion of an extremity with a decreased or even absent pulse. So ruptured aneurysms are associated with an extremely high rate of death if they are discovered after they actually rupture. So you may encounter a patient who is aware of having an aneurysm. Fortunately, the incident of a ruptured AAA has become less common in recent years with the advent of ultrasound aortic screening of high-risk patients. So these are typically, high-risk patients are typically men over 50 years of age with a history of smoking. So not all surgical repairs have to be done immediately, but they tend to enlarge over time. So when the patient tells you that they have an aneurysm and have an abdominal pain, these are serious emergencies requiring prompt transport to the appropriate hospital. So again, you're going to need to go to a hospital that can actually care for the AAA itself. So patients with a slow leaking AAA usually present with gradual developing abdominal pain, which can be described as sharp pain or tearing pain that may radiate to the back. So the associated pain with the rupture of a AAA is why back pain in older adults is considered highest priority dispatch in medical priority dispatch systems. So a sudden rupture of the aorta typically causes rapid onset of excruciating abdominal pain and back pain. Signs and symptoms are usually present at that point, and depending on the location of the AAA, there may actually be an inequality between the femoral or the pedal pulses. So again, on your signs and symptoms, it's going to progressive abdominal pain or often sharper tearing. It's going to frequently radiate to the back. The rupture causes rapid onset of that excruciating abdominal and back pain, and signs of shock usually are present. Again, possible inequality in the pedal pulses. So next one we're talking about is going to be the hernia. So a hernia is a hole in the muscle layers of the abdominal wall, allowing tissues, usually the intestines, to protrude up against the skin. This can be aggravated by heavy lifting or straining that causes the intestines to push through the weakened area in the abdominal wall. Such hernia will also cause a sudden onset of pain, usually after lifting. So a hernia may be palpated as a mass or lump on the abdominal wall in the creases of the groin area. So although it may be very painful, it is a life-threatening condition, and only if the hernia causes an obstruction or twisting of the actual intestine. So because the pain at the site of a hernia may indicate obstruction or strangulation of the intestine, all patients with painful hernia should be transported for further evaluation at the hospital. Signs and symptoms of a hernia are the sudden onset of abdominal pain, often following lifting, and you can have a palpable mass or a lump on the abdominal wall or crease of the groin. The next one we're going to talk about is renal colic. So under certain conditions, the kidneys may form small, hard stones. If one of these stones begin to descend down the ureter on the way to the bladder, it can actually cause severe flank pain that often radiates anteriorly to the groin area. So the visceral pain from such a kidney stone is often severe and may be associated with nausea and vomiting. Patients with this condition are described as, moving around or fidgety or writhing because they move around too much, trying to unsuccessfully find a position of comfort, and they're just not going to find it. That position of comfort is just not heard of with this type of an emergency. The next one we're going to talk about is cardiac involvement. So that is when you have pain from a heart attack, which may be felt as abdominal discomfort. So the pain often is described as indigestion or digestive discomfort, which is commonly felt in the epigastric region. So the area below that xiphoid in the upper center of the abdomen is where we're talking about. So all epigastric abdominal pain should be considered cardiac in nature until proven otherwise. So care for this condition described in your cardiac chapter. So your cardiac emergencies that we went through, care for this condition exactly like you would a cardiac patient. And the last one we're going to talk about is abdominal pain associated with the female reproductive system. So although abdominal pain associated with the female reproductive system will be discussed later in the chapters, it is, mentioned here just so you have an idea. So the most serious cause of abdominal pain related to the female reproductive system is ectopic pregnancy. So an ectopic pregnancy occurs when the fertilized embryo implants outside of the uterus in the fallopian tube or abdominal cavity. So as it grows, it eventually then ruptures and then frequently causing life-threatening internal bleeding. So the rule of thumb is that all women of childbearing age with low abdominal pain have ectopic pregnancy until proven otherwise by the testing at the actual hospital. So they should go in and they should be assessed. In this section, we're going to talk about the assessment and care of abdominal pain or discomfort. With assessment and care of abdominal pain or discomfort, there can be so many potential causes that you don't necessarily need to be concerned with field diagnosing a particular cause. Diagnosing can be very difficult even in a hospital setting where there's advanced diagnostic tests available and so forth. So you want to focus on your assessment process, and that will help you to perform a secondary assessment to describe the condition accurately and identify any potentially serious conditions such as, for instance, shock. So for the steps in the assessment process, you may observe specific concerns and points of interest in the patient that has that abdominal pain. So again, you're gonna focus on that. With your scene size up, as you approach and take the important scene size up steps, like you've been told multiple times that we do on every single call, you want to prepare to protect your face and your clothes in case vomiting happens to occur. Or odors can be clinically important. So for example, blood in vomit or feces creates a distinctly strong odor. And once you smell that one time, you're never going to want to smell it again. But if you do end up smelling it again, you're going to know exactly what it is. So identifying this odor early will actually help you identify potential shock. So your research for a mechanism of injury may help you determine if this is a traumatic versus a medical condition. Again, during your scene size up though, you don't want to forget that importance of the history in a patient with abdominal complaints. So if they have had abdominal issues in the past, you want to actually try to get that and determine that soon enough. During your primary assessment, you're going to obtain, as you approach the patient, information which is very valuable in determining the seriousness of that patient's condition and the urgency of your care. So again, walking up to a patient and looking at them and being like, are they sick or not sick? That's going to help you determine how fast you need to move. So first, the patient's level of consciousness will help you determine that the required airway care if needed. If the patient is conscious, you'll be able to begin talking to them and gain information. And a patient who is talking has an open airway, so just remember that. Unconscious patients require airway care, and any history will be obtained from either family or bystanders. So at this stage of the assessment, you will be able to notice the early signs of shock. So, for instance, an altered mental status, anxiety, pale, cool, or moist skin, and rapid pulse and respirations will alert you to shock long before you would take a blood pressure or see trends in that blood pressure. So those are the assessment pieces of your primary assessment that you'll eventually learn over time, but it does take time and it does take, lots of different calls and so forth. So the position of the patient also provides important clues. So does that a patient appear to be in pain? Is there guarding of the abdomen? Is that patient in the fetal position? At this point, you want to consider the application of supplemental oxygen to any hypoxic abdominal pain patient, if again at that 94% or less, or in any situation where oxygen saturation is deemed to be inaccurate. So maintain saturations of that 94% using that appropriate oxygen delivery device. You may be able to start out with a nasal cannula or a non-rebreather mask. But remember, if they're unresponsive, they have shallow respirations, 8 per minute or below, that's going to push you up to getting that bag valve mask. When you're talking about the history of the present illness, you want to have the patient describe the pain in their own words by answering your open-ended questions. So for instance, the onset, you're going to ask, when did it begin or what were you doing? The next one is P, provocations. What makes it better or worse? Is there any movement that makes it better or worse? What position makes it better or worse? And then quality, which is describing the sensation in your actual abdomen. Then you're going to go on to the region or radiation. When they point to its location, does it radiate or does it move? On the next one is severity. How bad is the pain? On the pain scale of 1 to 10 or 0 to 10, 10 being the worst you've ever felt, where do you put your pain at? And then time, how long have you had the pain or discomfort and has it changed? And a good one to ask is, what made you, especially if they've had the pain over time, is what caused you to call the ambulance now versus 6 hours ago? So what changed or what got worse? Then there's always that history that's specific to female patients. One of the things you should ask is, where are you in your menstrual cycle? Do you still have it? Is your period late? Do you have any bleeding from the vagina that is not menstruating or menstrual bleeding? And if you are menstruating, is your flow normal? Is it heavy? Is it lighter? And explaining that so they understand. Next is, have you had this pain before? If so, when did it happen and what was it like? Is it possible you are pregnant or are you using birth control? Some other ones you can ask is, have you ever had a hysterectomy? That's going to tell you straight out that that patient is not pregnant. So just keeping a few of those things in mind. I always like to ask people, do you have your gallbladder or appendix? Because that again can go to it. As far as female specific, you can ask them about it, if they've ever had any issues with their ovaries. Next is past medical history. So you're going to start out with your, obviously your signs and symptoms, and then you're going to move on to your allergies, finding out what allergies they had and what issues they had when they had that last allergy or the anaphylaxis issue. Then what medications they're on and what they're actually taking it for, because now there's a lot of medications that people are taking, and so for instance, one that I can think of off the top of my head is Wellbutrin. People want to quit smoking or have depression, and all of a sudden you have the same medication that's for two different things. You have Wellbutrin that they use for depression, and you have Wellbutrin that they use to help people stop smoking. So what are you actually taking that medication for? What is it prescribed to you for? Then their past pertinent medical history. So pertinent to what's going on with them right now is what you want to know. Their last oral intake. When did they eat or drink anything last, and what was it? And then events leading to the emergency. On a geriatric note, they have decreased ability to perceive pain, more serious causes of abdominal pain, more likely to be life-threatening, and may become complicated by medications. Next, we're going to talk about physical examination of the abdomen. So before you physically assess the abdomen, you will have to ask the patient, where does it hurt? The patient may have pointed to a spot or may have moved a hand around an area indicating diffuse pain or discomfort. This will be important for your physical exam. So first you want to inspect the patient's abdomen. What you're doing is you're looking for any distension, bloating, discoloration, abnormal protrusions, or other signs that appear abnormal or unusual. So you may have to ask the patient or family members whether the current appearance of the abdomen is normal or not for that person, because people have many different body types and shapes vary widely across all of us. So that's why you need to ask them, is this normal for this patient? Next is going to be to palpate the abdominal quadrants. So always palpate the area that has pain or discomfort last. If this area is palpated first and causes additional pain, it will mask or alter the patient's response to palpation of any other quadrants. So you want to palpate that abdomen using your fingertips of several fingers and gently press into the abdomen in each quadrant. So while you're palpating, you want to feel for rigidity or hardening and ask or observe whether this causes pain for that patient. So not only, feeling them, but actually watching their facial expressions. If an initial gentle palpation does not cause pain or discomfort, you may palpate a little bit deeper. So once you have found the pain, discomfort, or abnormality, there is no need to palpate that area any further. So you may also notice that they are guarding their abdomen. And the term guarding is used to describe two possible presentations. Either the patient's drawing their arms down across the abdomen, or the patient tenses the muscles before you actually touch the abdomen. So guarding is a voluntary or involuntary attempt to protect that abdomen and prevent any further pain to it. So with abdominal pain patients, you're going to do your baseline set of vitals and then every 5 minutes afterwards, including the pulse, respirations, blood pressure, skin color, temp and condition, pulse ox, and their mental status. With general abdominal distress, some will result from digestive system disorders, others could be cardiac or diabetic issues, could be food poisoning, or even the flu. So you want to assess and care for these patients with appropriate attention to their airway, particularly if that patient is vomiting. You always want to work to calm the patient to reduce anxiety and never give the patient anything by mouth. As far as patient care goes, you want to maintain that airway and be prepared to suction. Administer oxygen to the hypoxic patient and maintain oxygen saturations of 94% or higher. Again, if they do complain of difficulty breathing and their oxygen level is at 96, in the real world, I would say go ahead and give them a little bit of oxygen via nasal cannula. It might make them feel better. However, for testing purposes, you have them maintaining that oxygen at 94%. So place in the position of comfort and the left lateral recumbent for airway protection and transport to the appropriate facility. So something to think about. You have an 89-year-old female with a history of diabetes, hypertension, and gallstones and is complaining of nausea and dizziness about 20 minutes after eating. What could this be? Could it be diabetes? Possibly, but you just ate, so I would think probably not. Hypertension? Possibly. Or gallstones and is complaining of nausea and dizziness. Yes, it very well could be. After you get done eating, it could be gallstones that are flaring up. So some other things to talk about or to think about would be, what are the concerns with this specific patient? Is this an abdominal emergency, a diabetic emergency, or a cardiac emergency? How will you know, and what will your treatment be? So could this be a life-threatening? Yeah, if it's cardiac, for sure, yes, it could be. And then at that point, this patient is at high risk. But you want to be focusing on while you're focusing on your cardiac, your detailed assessment with the vitals and glucose and an abdominal exam should also reveal the true cause. Okay, so treatment would include initial assessment, history, vitals, your detailed physical exam, oxygen, positioning of the patient, calling ALS, and transporting again to the most appropriate facility for this patient. All right, let's do a quick chapter review. All patients with complaints of abdominal pain or distress should be transported to the hospital. These cases are difficult to diagnose without testing resources that are available at the hospital. As an EMT, your responsibility is primarily to assess the patient and report your findings. Diagnosing the cause of an abdominal complaint in the field is often more difficult and time-consuming than diagnosing in the emergency department, where there are many more resources available. Your assessment should include thorough patient history, physical exam, and vital signs. You want to look for signs and symptoms that can signal serious trouble. These include the sudden onset of tearing pain radiating to the back, vomiting blood or coffee ground-like substance materials, the presence of black, tarry stools, and signs and symptoms of shock. Emergency care will consist of protecting the patient's airway, oxygen as needed, placing the responsive patient in a position of comfort, or placing the unresponsive patient or patient with difficulty maintaining an airway in a left lateral recumbent position, and transporting the patient to the hospital. You want to take all appropriate standard precautions and carefully clean and disinfect equipment and the ambulance, especially if the patient has vomited or had diarrhea. Remember, abdominal organs provide a variety of important functions of the body. The abdomen can be divided into 4 quadrants with the reference to the midline and the umbilicus. Classifications of pain can help identify specific abdominal dysfunctions. Remember, assessment and management always takes a higher priority than determining the exact cause of abdominal pain. Knowledge of the characteristics of specific abdominal disorders can aid differential diagnosis when assessing a patient with abdominal pain. Care for a patient with abdominal pain should include treatment of immediate life threats, administration of oxygen, placing the patient in a position of comfort, and appropriate transport. Questions to consider. What are 5 signs and symptoms of abdominal distress? And describe the difference between visceral and parietal pain. Describe a condition that may be responsible for each. So remember, signs and symptoms of abdominal distress can include nausea, vomiting, diarrhea, pain, and distension. Visceral pain arises from organs in the visceral peritoneum and is general and nonspecific. The patient will not be able to localize it or point to the specific area. Parietal pain arises from organs in the parietal peritoneum and is often described as sharp, constant, and localized to a particular area. What is the emergency care for a patient experiencing abdominal pain or distress? And then name the 4 abdominal quadrants and how are the quadrants determined? So remember that emergency care for a patient with abdominal distress involves monitoring for airway problems if the patient is vomiting, placing the patient in a position of comfort, placing the unresponsive patient or the patient who is having difficulty maintaining an airway in the left lateral recumbent position for drainage from the mouth. Remember that there's 4 abdominal quadrants. They are the left upper quadrant, right upper quadrant, left lower quadrant, and right lower quadrant. These are determined by the midline on the umbilicus. Critical thinking. You are called to a patient with abdominal pain. He describes the pain as severe and says it has been on and off over the past several days, becoming severe within the last hour. What are you going to do? What additional questions would you ask the patient? Well, your question should focus on where the pain is, where it starts from, and so on. So questions asked will be determined by the history of their present illness or your other steps in your assessment process. And then in what position would he likely be most comfortable? Well, the best position is likely to be the one where there is least pressure put on that painful area.